Okay, moving on to our next case. We have a never smoking 57-year-old gentleman with stage 3A, that is N2 node positive lung adenocarcinoma with a single non-bulky mediastinal lymph node that was positive, who's felt to be a good candidate for surgery. His molecular marker testing shows an ALK rearrangement. What do you favor as an initial treatment strategy? So I'll start with Anna, your thoughts here.
Yes, of course. I think that in this case is one, again, that we would discuss at our tumor board and consider and think, should this patient, discuss with the patient, what would they prefer? Going straight up for surgery, in which many of our patients, I would say, have strong feelings towards getting tumor removed completely, versus trying to provide here, is there a role for neoadjuvant chemotherapy? Given the fact that this patient has an ALK rearrangement, I would not use regimens which we discussed on the prior case of immunotherapy combined with immunotherapy to avoid toxicity, and plus those patients who were excluded from all of the trials. So here, if it is a very good surgical candidate indeed, and the surgeons would offer surgery, I would go for surgery and offer chemotherapy in the adjuvant setting alone without immunotherapy. The other question comes if you have a clinical trial like Alchemist open at your particular institution, then this should be discussed and offered to the patient. But that would be my initial thoughts.
Now, Anna, can you clarify? So if you put the ALK rearrangement aside, so in your institution for N2 positive patients, what percentage go to upfront surgery versus induction therapy followed by surgery?
It will really depend on size also of tumor, and if lobectomy is achievable. To be very honest, I would say most patients are going straight for surgery, but we've been doing induction neoadjuvant chemo for a couple cycles. We've been doing it regularly, to be honest, on patients who do have larger, bulkier tumors without clear N2 disease, though, I would say. So taking both things into account, this patient we would take to surgery if the surgeons felt they were a very good surgical candidate.
Okay. So Stephen, I'm hearing, bulk plays a role, decision-making. What about, I guess, first question is putting the ALK rearrangement aside, for stage 3 N2 positive patients at your institution, role of upfront surgery versus induction therapy, and then we can talk about the ALK rearrangement.
Yeah, the ALK makes it really interesting. I will say if it's N2 documented, N2 sort of biopsy proven, we do neoadjuvant for all of our patients first. And so we don't take anyone right to surgery with N2. If it's bulky N2, we're probably going to go a chemoradiation route and really not favor surgery at all. At least up front. If it's single station bulky, then we can talk about neoadjuvant therapy and consider it. But generally, if it's bulky nodal involvement, we're going down maybe a chemoradiation direction. We try to make our decisions about resectability and the appropriateness of surgery up front, and that's sort of based on initial response to therapy. So if it's single station, non-bulky mediastinal involvement that's documented, again, not just on PET, but biopsy proven, we would do neoadjuvant chemotherapy 4 cycles up front.
Okay, I would say that mirrors our practice as well. I would say that bulky disease, especially in light of the Pacific data, I feel perfectly comfortable definitive chemoradiation followed by PD-1, but non-bulky, especially 1 or 2 nodal stations, usually we're doing induction therapy followed by surgery. Okay, how does the ALK rearrangement change your decision-making here?
Yeah, that's a great question, and it really is tempting to just give an ALK inhibitor. They're so well tolerated, they're so effective, you can almost guarantee some reduction. Question is, what does it mean? Because we often don't consider TKI therapy to be curative, and would it influence the surgery in any way? I think most of our surgeons would probably say no, that it wouldn't, even though we get an initial response. I think that I agree exactly with what Anna said, that if we have a trial, that's definitely the route we want to go. But that's sort of an easy way out, right? So without a trial in this setting, I could say that we would probably do neoadjuvant chemotherapy, because I think that contributes to the rate of cure. Surgery. We would not do radiation for N2 based on the LungArch study. And off study, despite the lack of data, I probably would offer adjuvant ALK TKI therapy.
Yeah, I think it begs the question, right? Which is that, we now have 9, targets in the metastatic setting, right, with FDA-approved therapies, and it's going to be impossible to do randomized phase 3 studies for all of them in the adjuvant, neoadjuvant consolidation period, just given the rarity of some of these alterations, how long, and so how much data do we need to start extrapolating? Is EGFR enough? Stephen, like you, I would be tempted to give adjuvant ALK inhibitor here, acknowledging the complete lack of data, except I would draw the parallel with EGFR and say, in this case, I'm going to extrapolate there. Again, acknowledging complete lack of data.
Would you make the same decision if the patient was not a surgical candidate and you went the chemo-RT route?
I would, yes. And just between us, right? No one, just the three of us. We're not telling anybody else. But yeah, 100%. I mean, and I think of ALK is a little different because generally, well, in EGFR, the response rate, and this is mostly based on work that you led, Justin, but the response rate is very low in EGFR, but it's non-zero. But for ALK, it's pretty close to zero. I mean, we generally don't see responses. I think of ALK and ROS1 as pretty immune non-responsive tumors. And so I really don't see much benefit with durvalumab in that setting. So after chemoradiation, again, despite no EGFR data, even until Laura reads out, but I just don't think durvalumab makes sense. I think the rate of relapse is so high. And again, it maybe even more so because ALK is so CNS tropic that the risk of brain metastasis is so high that I would favor TKI in that setting. And this is, heart to heart with the patient saying that we don't have evidence for it, that there are side effects, that I don't know if this is something that they need or will derive benefit from, but I still think that there's some value in it.
I agree with you. I also think that for ALK in particular, it has such a metastatic phenotype that for someone presenting with stage 3 disease, unfortunately, the risk of recurrence is going to be so exceedingly high that adding the ALK inhibitor post definitive therapy makes sense.
I'll sort of acknowledge also, from a public health standpoint, these are very expensive medicines for years. We don't know duration of therapy. And, I would not consider that standard. I would say the standard option would not be to use TKIs in that setting. And ideally, what would work for is some sort of biomarker, some sort of marker of residual disease to tell us that this person is in fact not cured and that will need more therapy. In the absence of that, we have to make our decisions in the individual setting. And for a stage 3A ALK positive, I agree. My concern for relapse is so high. And ALK, I think, the therapeutic window is so high because I think the ALK inhibitors are just so well tolerated. When you look at drugs like alectinib, brigatinib, I think the tox is so low. If you look at some of the other agents where maybe the toxicities are a little more notable, especially sort of chronically, maybe that therapeutic window is a little smaller. And I think their decision gets a lot tougher, like for MET, for BRAF. I don't know if I make the same recommendations there, but for ALK, the risk of metastases I think is so high and the tolerability is so good that I think I would recommend it, at least discuss it with the patient. I don't know if you have a different line of thinking, Anna.
No, I agree, I would. And the other question I was going to pose, which is not really this case, but when we're going into the unresectable space on a patient who you would treat with definitive chemo-RT, do we really believe that putting the patient through all that toxicity of chemo plus radiation versus bringing on unresectable disease earlier and ALK TKI, where do we where do we draw the line of risk and benefit and toxicity in this space too. And I don't know that we have tons of data to guide us through.
Yeah, it's a good question. I mean, I think in my view, whenever there's a potential curative therapy, you know, I think we have to prioritize that. So I wouldn't not use chemoradiation, definitive chemoradiation in someone with stage 3 who has an ALK rearrangement. I still think we have to do that. But you know, it's how can we expand treatment, and you know, to your point about, you know, toxicity, you know, the biggest fear I have in that situation is really a pneumonitis risk. That's where I worry the most.
Definitely. No, I agree. I mean, my practice is to give the chemo radiation, as I think everybody would agree. But I think as I am doing it similarly and taking into account when you have an elderly patient who their ECOG may be semi-borderline, we're putting them through daily radiation. You may not be able to get all of the chemotherapy in because of counts and other limiting factors with toxicity. The percentages of cure also and the data is not the greatest. And adding that data we're having for TKIs from extrapolating from the EGFR space really is on the FS and not particularly for overall survival, makes me wonder and question. And I think all of these things are things we have to talk through and wonder what are the best steps moving forward.
Yeah, I think you have to ask the question. I think it's a great question. You have to challenge the paradigms and the dogma. And, you know, is there more value in starting with TKI and then using radiation or surgery as some sort of consolidation? I think those are the types of questions that we'll be faced with.
Well, great case and great discussion. So I think we're going to hand things over for a discussion of the next case.